All right, welcome. In this explainer, we're going to dive deep into electrocardiographic analysis. We're going to treat this like a university-level lecture, really focusing on building a solid, systematic method for interpreting any ECG you see. We'll start with the basics, get our foundation right, and then apply that method to understand the specific problems that the P wave can show us. So let's get started.
So here's our game plan. We'll kick things off by building that systematic method for analysis and use it to define what a perfectly normal ECG tracing looks like. From there, we'll zero in on the P wave, really digging into what it tells us about atrial enlargement, any conduction issues, and different heart rhythms. And we'll wrap it all up by clarifying some of the key diagnostic distinctions you've got to know.
Section 1. Systematic ECG Analysis. Let's start with what is, without a doubt, the most critical principle. To interpret an ECG accurately, you must use a systematic approach. Every single time. Trying to analyze on the fly or just spot patterns is a recipe for mistakes. A methodical process is really the only way to make sure you get a complete and correct evaluation.
And this is that essential sequence. You have to follow it every single time. First up, check the calibration and identify the rhythm. Then, step 2, calculate the rate. Step 3, and you have to be meticulous here, measure the key intervals, the PR, QRS, and QT. Step 4, determine the mean QRS axis. Once that's done, you move to step 5, a detailed analysis of the waveform morphology, looking at the P, QRS, and T waves one by one. And finally, step 6, assess the R wave progression. This exact sequence needs to become second nature.
Okay, section 2, the normal tracing. Now, let's put that method into practice with a normal ECG. Before we can even begin to spot the abnormal, we have to know the normal inside and out. This tracing is going to be our reference point, our baseline for everything else we look at.
Let's apply our system right here to this tracing. First, you can see the standard calibration marks right here. The rhythm is regular. Just look at the consistent spacing between each of the beats. And we see a positive P wave right before each QRS complex. And that PR interval is fixed. This confirms we're looking at a normal sinus rhythm. The rate, as you can see, is 65 beats per minute. This is our perfect baseline.
Now, here's an important detail on a normal ECG, the presence of these small Q waves. These are not a sign of a problem. They're what we call normal septal Q waves, and they just represent the initial firing, the depolarization of the interventricular septum. The key here, and this is crucial, is their duration. As long as they're less than 0.04 seconds wide, they're considered benign. Now, the one big exception is lead V2. Any Q wave there is considered abnormal and definitely needs a closer look.
So here are the numbers that really quantify our normal baseline. The PR interval is 0.16 seconds, the QRS is 0.1, and the QT is 0.4 seconds, all perfectly normal. We also see this little 1 millimeter ST elevation in leads V1 to V3, which is a known normal variance, so don't let that throw you. Every single parameter here confirms this is a normal ECG.
With our baseline firmly established, we can now pivot to a focused analysis of the P wave. Think of this waveform as our primary window into the electrophysiological state of the atria. It reveals critical information about the size of the chambers and, importantly, the origin of the cardiac impulse itself.
Not all leads are created equal when it comes to assessing the P wave. We really focus on two. Lead IV is fantastic because its axis is perfectly lined up with the normal flow of atrial depolarization, which makes it great for assessing amplitude. And then there's lead V1. It sits perpendicular to this vector, which is unique. It allows it to see the right and left atrial forces separately, revealing these diagnostically crucial biphasic shapes. Before we can really analyze the pathologies, we have to get this concept down: retrograde depolarization. All it means is that the atrial activation is traveling backwards, from the bottom to the top. Now, this can only happen if the impulse originates from somewhere it shouldn't, an ectopic focus, somewhere low in the atrium, the AV junction, or maybe even the ventricles. And the absolute unequivocal sign of this is a negative or inverted P wave in lead 2.
Section 4, atrial enlargement. All right, now let's get into our first set of pathologies. We're going to examine the specific P wave shapes, the morphologies, that tell us the right or the left atria have become enlarged.
This ECG is a classic textbook example of right atrial enlargement, or RAE. The defining feature here is all about increased P wave amplitude. What you're looking for specifically are these tall, peaked P waves in lead 2 that are greater than 2.5 millimeters high. That increased voltage is a direct result of the increased muscle mass of that right atrium.
Okay, now for left atrial enlargement, or LAE. For this one, the key diagnostic lead is V1. The criterion is a biphasic P wave, where that terminal negative portion, which represents the delayed left atrial depolarization, is really prominent. Specifically, it has to be at least 1 millimeter deep and 1 millimeter wide. Think one small box by one small box.
So, what about biatrial enlargement? Well, it isn't some separate, unique entity. It's actually a diagnosis you make by combination. To make this call, you have to find the electrocardiographic evidence for both conditions on the very same tracing. You need the tall, peaked P waves of RAE in lead I, and you need the deep, wide, terminal negative component of LAE in lead V1.
Section 5. Conduction and Rhythms. All right, now we're going to shift our focus a little bit. Instead of looking at the size of the atria, we're going to use the P wave to analyze the dynamics of atrial conduction and figure out the precise origin of the heart's rhythm.
This one represents a subtle but really important condition. An intraatrial conduction defect shows up as broad and often notched P waves, especially in lead 2. So what distinguishes this from LAE? It's the absence of the specific criteria for LAE back in lead V1. It tells you there's a delay in conduction through the atria, but without that definitive evidence of chamber enlargement.
Here we've got two great examples of ectopic rhythms. And like we defined earlier, that negative P wave in lead 2 immediately tells you the impulse is not from the sinus node. This is retrograde depolarization. The tracing on the left is a low atrial rhythm, and the one on the right is an AV junctional rhythm. So the big question is, how do we tell them apart?
And here's the crucial point. The PR interval is what differentiates these two rhythms. It's the whole ballgame. Both of them will have a negative P wave in lead 2, right? But in a low atrial rhythm, the impulse still has to travel through the AV node, and that causes a normal delay, giving you a PR interval longer than 0.12 seconds. In a junctional rhythm, however, the impulse originates at or very near the AV node, so it bypasses that delay, and this results in a characteristically short PR interval, less than 0.12 seconds.
To wrap things up, let's just crystallize some of the more nuanced morphological distinctions of the P wave. These little subtleties are absolutely vital for achieving the highest level of diagnostic accuracy.
Here's a really sophisticated diagnostic point, and it's all about that biphasic P wave in lead V1. While we look for specific dimensions in LAE, there's another clue. In right atrial enlargement, the transition from that initial positive part to the negative part is typically sharp and abrupt. But in left atrial enlargement, reflecting that delayed conduction, this transition is often more gradual, or what we call slurred. This statement serves as a really powerful clinical rule of thumb. Lead V1 is consistently the most biphasic lead in a correctly recorded ECG. And this feature isn't just useful for diagnosing atrial enlargement, it's also a quick check for correct precordial lead placement, and it can raise your suspicion for an ectopic atrial tachycardia if that expected biphasic pattern just isn't there. And that leaves us with a final question to think about. We've just applied a rigorous, systematic approach to understanding the atria through the P wave. So, the logical extension is to ask, how does this same foundational method, establishing a baseline and meticulously analyzing morphology, allow us to decipher the even greater complexities of ventricular function as reflected in the QRS complex in the T wave?